Assalamu alaikum, this is Shamama, and today we're going to discuss a very important topic of infections in the genital tract, that is pelvic inflammatory disease. Now, what is pelvic inflammatory disease? It is basically, first of all, talking about its definition. It is an infection of the female reproductive organs. Why? Because of transfer of the sexually transmitted bacteria from the vagina up through the endocervix to all the higher genital tract or the higher reproductive tract. This is whole about the pelvic inflammatory disease. Now, talking about its pathophysiology, which is very important, of course, that if we know the pathophysiology, we can easily understand the whole disease. So, as we know that normally our vagina is consists of normal flora, means a lot of bacteria and fungi are present within the vagina normally, but they are not allowed to cross the vagina. uh, they are not allowed to move from the vagina, cross the cervix and reach the upper reproductive tract. Why? Because within this internal os and external os cervical area, here first of all it is a narrow area, secondly it is mucus filled. This mucus, it contains of course the immune cells, plus it itself has some protective mediators. So all these, they combined, do not allow the bacteria to move up through the cervix and so on and cause the disease. Okay, now, but normally in all conditions this mucosal lining is intact, but in case of menstruation, during menstruation or during sexual intercourse, this lining is not present there, and it is prone that time is a high time when bacteria can pass and cause the disease upward. So now this was actually, we discussed the normal physiology, but what happens if there is any predisposing factor that comes now? Okay, just wait a second. Yeah, any predisposing factor, it comes and it causes this mucous lining to get disturbed, and as a result now there is a free pathway for bacteria to move up. Now from the vagina, the normal flora, which is sexually transmitted bacteria, they then move up from vagina through the cervix, endocervix, into the uterus, to the fallopian tubes, to the ovary, and so on. Now, the spread of disease is in a sequence, very important. First of all, from vagina goes to the cervix, there it causes cervicitis, further progresses to uterus causing endometritis, then to the fallopian tubes here causing salpingitis, then from here to the ovary causing ophiritis, and from ovary, if it further spreads to the whole peritoneum cavity in the peritoneum, then it causes peritonitis, and after it then spreads to all the abdominal organs including our gut, our liver, etc. And then if still it is untreated and continue to proceed, then it spreads to whole body causing generalized sepsis, and while in the ovary it causes tubo-ovarian abscess also. So this is the whole course of disease and its whole pathophysiology. Now what happens that if there is an acute pelvic inflammatory disease, what happens that it first of all starts most commonly during menstruation. Why? Because that point the genital defenses are lost. Of course, we've discussed before, mucosal lining is not present at that time. Sorry. So what will happen that most common site is endosalpinx of the fallopian tube. Now what is this? It is the mucosal lining of fallopian tubes. From here the disease starts, and the bacteria invades there, and there it start to cause the damage of epithelium, of the cilia, of microvilli, and now the cells are being died, they are sloughed off, and an inflammatory reaction has started there. Now, this acute inflammatory reaction brings, of course, the inflammatory mediators, inflammatory cells there, and activity. A fight starts there, and ultimately, end result of which is that the dead cells exudate, inflammatory cells, it start to cause inflammation and edema and exudate of the mucosal lining of the fallopian tube, which will lead to decrease in the lumen size, and ultimately net result, both the lumens of the fallopian tubes, that is coming back to this diagram, this fallopian tube, its abdominal opening as well as its uterine opening, both become closed, and that is a very serious complication. We'll talk later in the complicated section. So this is how the disease occurs. Fine. Moving on, that how will the patient presents to us, we'll talk about the clinical features. Now in clinical features, first of all, for remembering symptoms, just remember three things. Patient will have pain repeatedly, patient will have pain, patient will have discharge, and patient will have bleeding. Fine. Now what will be the pain? Characteristic point is that there will be bilateral lower abdominal pain. Okay, plus pain during menstruation called dyspareunia, pain during urination called dysuria, pain during sexual intercourse it is called dyspareunia, and pain during menstruation is called dysmenorrhea. Sorry. So these kind of pains will be presented by the patient when she will be giving history to you. Moving on, there will be an abnormal vaginal discharge. These two are characteristic findings. Fine. Then there will be intermenstrual bleeding and or postcoital bleeding. Postcoital bleeding is after sexual intercourse, that bleeding that is present. And if the disease is severe, then there will be generalized sepsis. Okay, moving on to the signs. Now signs are those features which we see on examination, which the doctor finds. Okay, so when we examine the patient, we find that on abdomen we find an adnexal mass. Now basically this mass is because of edema, inflammation, and the exudate or pus that is accumulating in the whole disease in the fallopian tubes. So adnexal mass will be seen first. Second, the pelvico-abdominal, like abdomino-pelvic tenderness. Why? Because of course of infection and inflammation, tenderness will be seen. On examination, cervical excitation will be seen. Now, because of infection, temperature will be raised, and fever, high-grade fever, it's a characteristic finding of this disease, plus these three examination findings. Now these points we'll discuss in the diagnostic section. Okay, moving on to the diagnosis. Now how we will diagnose this patient? First of all, we go for CBC, our general labs. So first we go for CBC. Now in the CBC, it's white blood cell levels initially in the acute phase of disease. Why they will be raised? Because they have come there to rescue, and they have to start an inflammatory reaction. So first, in acute case, white blood cells, particularly the neutrophils, they will be raised. But what if the neutrophils are less, neutropenia, then it indicates chronic PID. Why? Because now neutrophils have been continuously working and dying, and they are being used up, so it indicates chronic PID, neutropenia. Moving on, that if there is acute reaction going on, then ESR and CRP, they will be raised, and if they are normal, then it indicates that chronic PID is present. Okay, moving on. Now we know that it has two important differential diagnoses, that is pregnancy, ectopic pregnancy, and sexually transmitted diseases can also be seen here. So we go for pregnancy test. It's a very important test. We have to do it to rule out ectopic pregnancy. Okay, and other sexually transmitted infectious diseases testing is also performed. Then we know that in clinical features we had a mass, so whenever there is a mass, we go for ultrasonography to assess its location, its site, its size, plus that whether abscess is present there or not. That's all. Last, we go for laparoscopy. Laparoscopy is the gold standard investigation in this disease. I repeat, it's a gold standard investigation, and it's a very important MCQ too. So what we do in laparoscopy is that we find that, okay, which is the site of the disease, then what is its extent of the disease, how much damage has occurred, and in the fallopian tube particularly we see adhesions and the scarring, and all the tube changes like hydrosalpinges of the tubes. These all are seen through the laparoscopy. Okay, this is how we diagnose the patient. Moving on, that how we will treat the patient. Okay, now this patient is treated. First of all, I have made a mnemonic for this treatment for mild to moderate disease. OM called CDM. Okay, OM called CDM. So OM is the first regimen, CA is the second regimen, and third is the CDM is the third regimen. So these are the three options. Out of these, this OM is the most appropriate, you can say, or best regimen is this OM1. Okay, now of this OM, but it means ofloxacin and metronidazole. These two are given together orally. Now it's a rule that 2 times the drug are given 2 times for 2 weeks. So remember the word 2 here. Twice daily for 2 weeks, ofloxacin plus metronidazole. CA is ceftriaxone, whose IM injection single dose is given along with azithromycin, of course, twice daily for 2 weeks. Third regimen is ceftriaxone, same IM injection single dose, plus doxycycline, same twice daily for 2 weeks, and metronidazole twice daily for 2 weeks. These three combined are is a regimen. This is a regimen, and this is a regimen. OM regimen is the most common regimen we given in mild or moderate disease, of course in outpatient department patients we give this disease. Okay, moving on to the severe disease. Now in case of severe disease, what we do is, first of all, immediately we require hospitalization. Why? Because closely monitoring is required and many other points. So what are the indications when we will hospitalize a patient? First of all, just remember the same theme: whenever the disease will become severe, we will hospitalize the patient. Okay, so what was happening in this disease? Infection. So if a patient is having severe infection, first indication, it will progress ultimately to severe generalized sepsis. So if that develops, we hospitalize the patient. Second, pain was the major complaint here. So if the patient is having severe pain and she requires strong analgesics for its treatment, for her treatment, so then we will hospitalize her. Fourthly, if the already treatment which I am giving to the patient is not patient is not responding to the treatment adequately or is not responding at all, then we will hospitalize the patient to switch to the severe regimen. And lastly, if the mass, we talked about the mass is a problem here. So if the mass has developed now an abscess, or we have a suspicion of developing abscess within it, so even then we hospitalize the patient. Now once we have hospitalized the patient, how we will manage it? So the third regimen of the above mnemonic, CDM, is used here, ceftriaxone, but now we go for IV treatment, of course in severe cases. So ceftriaxone IV 2 gram plus doxycycline IV 2 times daily plus metronidazole IV 2 times daily. This regimen is used for severe patients. Okay, plus if the female is having IUD present, if that is the predisposing factor, then we will remove the IUD from the female. Moving on, that if the female is pregnant, now pregnancy is like we have to very carefully choose the drug regimen in case of pregnancy because there are many contraindications of many of the drugs. So for it I have made a mnemonic very simple: in pregnancy, avoid dog and prefer cam. Okay, so from dog is doxycycline, ofloxacin and gentamicin. These three are contraindicated. I repeat, they are contraindicated in pregnancy. And cam, ceftriaxone, not triaxone, cefotaxime plus azithromycin plus metronidazole. This is the preferred regimen for a pregnant lady. Plus, now in that case, since it is a sexually transmitted disease, so if we're treating the female, we will also treat her sexual partner. We will simultaneously screen him and start the empirical therapy with preferably azithromycin if he is found positive for PID. Moving on to the last therapy, that is surgical option. And what we do is, if the abscess is bigger in size, we will drain the abscess, or if the infection or the damage has a lot much damage the tube and the ovary, so we go for resection or removal of the infected tube and ovary. That is also surgical option. Now lastly, we'll discuss that what are the complications if we don't perform the treatment adequately, and the risk factors. Now for the risk factors, again I have made a mnemonic that, okay, we're talking about a female, fine, in which some uterus problems are occurring and it is a sexually related disease. So talking about the female, what can she have the risk factors? Like if she's having a history of certain diseases like gonorrhea or chlamydia infection or bacterial vaginosis, sexually transmitted disease, or a previous pelvic inflammatory disease infection, these are history, or if she is a cigarette smoker, these are risk factors for PID development. Then talking about her uterus. Now in the uterus, whether she has implanted something or she has you can say tickled any area, or she is just touched any area of a uterus. So these 2 points. First of all, she has placed IUD. Now the IUD placed was not under sterilized measures, and if it was under sterilized measures, she didn't maintain her hygiene adequately, so that can be a cause. Then if she has undergone douching is basically frequent irrigation or of the area. So if it's uterine douching, means of course uterine irrigation. And then it's instrumentation, that recently she has used some instruments on her uterus, so that can be a predisposing factor. Why? Because it will of course disrupt the mucosal lining, and there are chances of having infection. Okay, from the sex, now since it's a sexually transmitted disease, so what factors will be associated with the sex? If she has a multiple sexual partners, if her partner with which she's having sex, her male partner, he is having untreated urethritis, then the disease can spread. Plus if she's having sex during menses, then it can cause her, because we know during menses our genital defenses are reduced or as such absent. Then another cause is the sex onset at a younger age. So these are all the predisposing factors or the risk factors. Lastly, talking about the second lastly, of course, talking about complications. Complications are, you don't have to cram complications. Okay, but what's happening is this disease infection. So what if the infection spread extensively? Then what will happen? Generalized sepsis will develop, or the adnexal mass will develop abscess within it. So that is a complication. Or a rare complication is that it spread through the peritoneal cavity to the liver and causes perihepatitis. Then because of it, there will be Fitz-Hugh-Curtis syndrome. It's a rare syndrome, and typical is violent string appearance is seen. And now we know that the main pathology was occurring within the fallopian tubes, and there was some adhesions and scarring and closing of her tubes occurring, of her opening occurring. So according to that mechanism, what complications can occur? That first of all, either ovum, first of all, there are very less chances, because since adhesions has occurred and less lumen is present, so there are less chances for ovum to enter the fallopian tube, and hence the fertility to occur. So subfertility. Or if it has entered, the ovum has entered, then it is unable to move forward to the uterus, so pregnancy will occur here in the fallopian tubes, ectopic pregnancy. And because of ectopic pregnancy, we know there is a severe abdominal pelvic pain, that can be a complication. Or either ways, if there is complete blockage of the abdominal opening of fallopian tubes, then infertility can be a complication. Okay, moving on to the DDs. Now DDs are very important. We should know DDs of every disease so that we can diagnose adequately and manage adequately. So talking about differential diagnosis, two very important DDs are ectopic pregnancy and endometriosis. How to differentiate them from this disease, PID? That is that in PID, fever, vaginal discharge, and thirdly lower abdominal pain is very characteristic. But in ectopic pregnancy and endometriosis, although abdominal pain and abdominal pelvic pain is present, but vaginal discharge is not seen and fever is not common. Other differences are surrounding structures, like appendicitis may be present, cervicitis can be confused with it, any UTI can be confused with it, or ovaries are present, so ovarian cyst, ovarian tumors, ovarian torsion. So these are all the differential diagnoses. Okay. This was all about the pelvic inflammatory disease. I hope you liked the video. If you do so please like, share and subscribe, and do share the videos with your fellows so that Max can avail the benefit. And thank you so much. At the end, please remember me in your kind prayers. Allah Hafiz. See you in the next video.